do that.
No, it has not happened, Vivek. Just a minute. For a minute. Yeah, I think we are live on YouTube now.
Hello.
So I'll request
Hello?
all of you to mute
You
the
can mute
namaskar.
everyone,
audio.
Roshan, then unmute.
Yeah, I'll mute everyone.
हाँ जी बोलो.
Okay, just a minute.
नहीं अभी तो नहीं होएगा. अभी तो हॉस्पिटल बंद है हमारा महीना 1.5 महीना.
Okay, and I will unmute Dr. Vivek Pandey. Vivek, can you hear me?
Yeah, I can hear
Yeah, you can go ahead. We are live on YouTube. So solve it. We can see your screen and we can hear you. Vivek.
Thank you, Dr. Roshan, and thank you, everyone. I think you have been continuing a great job by continuing this discussion on various topics of the knee and shoulder for a extremely long time. We have been learning a lot, and in this series today we come up with the discussion about a subscap tear. So in the most of the time when we discuss the rotator cuff repair, we end up discussing a lot about supra, infra, this, that, somehow it goes on. And especially I personally believe this talk is going to open an eye for the people who do a lot of mini open. They see the MRI and they just say, okay, supraspinatus is torn, and just do the mini open. In the mini open, the classic mini open, the deltoid split, which is being done, it is difficult to see what's going on with the subscap. You can add the max to the biceps tenotomy, but from the same incision, I have myself seen it's not easy to tackle the subscap, especially if it is a minor ones or even the major ones. So there comes the role of, if you have been learned and trained yourself again and again over and over to look at the subscap, because the health and the treatment of the subscap in an appropriate fashion will take you a very long way in managing the entire rotator cuffs. So let's start with overview of subscap tear. Here I'm going to discuss a bit about the anatomy, the function, and then the classification, how the subscap tears are classified, followed by a bit of overview of my treatment, and then the JC will look after the rest of the things. So I'll not go into the treatment details, how to do the things, but just an overview. So we know that this is one of the largest cuff muscle among all the four, but the more important part is it has got the largest footprint on the lesser tuberosity, very big footprint, more than the larger than the supra and infraspinatus. It has got superior 2/3 as a tendon and only inferior 1/3 as a muscle part. If you look at the attachment, it looks like, like Americans say, it's like a area of the Nevada, from top to bottom, it's almost like 2.5, and in some cases it can stretch up to almost 3.5 to 4 centimeter. It's a trapezoid attachment onto the lesser tuberosity of the shoulder, just medial to where the biceps groove is. And the biceps and the subscap, they share a very intricate attachment, very intricate relationship. The biceps is, held on to a sling, the anterior and posterior slings. And then you have just ahead of that is the subscap. So this is usually, it is superior 1/3 is superior 2/3 is tendinous and inferior 1/3 is muscular in origin. I'll not go much into the anatomy part, but I'll just go ahead with the function. It is one of the major internal rotator. It's an anterior stabilizer. And we all know that what is its function in the force couple balancing. It is the horizontal force couple balancer. And why anterior stabilizer? We know that, if subscap is not perfectly functioning, patient can have actually recurrent dislocation. So if an elderly person who is having recurrent dislocation, one must always look for either anterosuperior or posterior superior cuff tears. The patients who have a completely deficient supraspinatus, even if you manage to get back the infraspinatus and the subscap and balance the horizontal force couple, this sometimes is enough to get back the 2 center of rotation of the glenoid and the head of humerus at the same level, and the patients in the due course of time, they gradually start elevating their shoulders in a much perfect fashion. When we go to the subscap tears, both degenerative and traumatic are common. They are often underdiagnosed. 27 to 69% to 70%, almost various series talk about it means. And a lot of time, especially in the beginning of your career, when you are in a hurry, when you have not been really trained how to look for the subscap tear, you are going to miss the subscap tear. Isolated tears are not so common. Most of the time it is either in the combination of the supraspinatus or it is a combination of the supra, infra and the subscap tear. For me, when I do arthroscopies, I find the articular side, that is towards the arthroscope side, more common as compared to the bursal side. When you look at the clinical presentation of a subscap, unlike the supraspinatus and or infraspinatus, whose presentation could be pain and along with the difficulty in elevation. So you will find them, they'll say, okay, my shoulder does not go up. Whereas the subscap tear are very funny. They present often with the pain. Some of them will say that I find difficult to smash, because when you smash, you take your arm outwards, the shoulder outwards, that is external rotation, and then you really need good power to internally rotate. So the subscap is gone or subscap is torn, patient will find difficulty to smash. There may be pain on overhead abduction and external rotation aber, because that's the position in which the shoulder is really stretched out. Sometimes patients may have a instability-like features, especially in older individuals who have large anterosuperior cuff tears or torn during the instability episodes. Now, this is one very, very, very important slide, and I think that may be quite important for all those who are in the beginning of their career. Is like when we probably about 14, 15 years back, when we were learning the shoulders, we were often making an isolated diagnosis of biceps tenosynovitis. So you put your finger here in the lesser tuberosity groove or adjacent to the biceps, and you realize, and there's some pain. And we often used to say, okay, this got biceps tenovitis, and you give an isolated injection into that. Now that area where the biceps groove is and the lesser tuberosity is extremely close. I personally feel it's extremely hard when you point your finger, you won't be very sure, are you putting your finger over the biceps groove or you actually touching the subscap? The point to be learned here is isolated just mere biceps pathology is not very common. It often exists along with the subscap tear. So don't make a diagnosis of chronic biceps pathology alone. Always suspect a subscap tear, and you can go ahead with some kind of an investigation to confirm or to rule out that there is no subscap tear either. In the examination, we may find the joint line we will tender anteriorly. Bicep signs could be there. O'Brien's may be positive. So O'Brien's is one sign which is a funny sign, you know, unless and until you got the typical age group of, let's say, the 20s and very early 30s, O'Brien's sign, it should be interpreted in a very lighter way because it will be positive in many of those conditions. Internal rotation often is weak in the patients who got more than the partial tear. Napoleon peripristine, negative in partial tear. Bear hug is a bit more sensitive in partial tears. Gerber lift off is a fantastic test, but I usually avoid doing because often it happens in my hands that my patient don't understand what exactly have to do. And if there is a stiffness, it's a stiff shoulder, then the patient cannot internally rotate. Hence, doing the Gerber's test is difficult. So I usually rely on the belly pressed sign, where in the normal side, the angle between the wrist, the hand, wrist, and the forearm is almost a straight line. Whereas if it is a torn one, you can see an angle coming up here. And in a complete tear or a complete full thickness tear, often when you do the external rotation, as compared to the normal side, there will be extra external rotation. So if you find all these signs plus along an extra external rotation on one side, you should suspect type 4 and above tears. Investigation, ultrasound is an excellent tool, but limited use in stiff shoulder where ER is limited. And it cannot diagnose the fatty infiltration and atrophy because the subscap is quite inside the rib cage. So MRI remains quite superior. For all this, you can see the fatty infiltration, atrophy, retraction, bicep status, everything, partial tears, bursal side, articular side, everything can be perfectly assessed with the help of the MRI. This is the most common classification we all follow, including me. I follow the Lafosse classification, which is classified into 5 types. So type 1 is just the superior third. There's a minor fraying, or sometimes there's a partial tear. Superior, the type 2 is superior 1/3, but it's a full thickness. Type 3 is superior 2/3 full thickness. Type 4 is complete tear, but it's a congruent joint. And type 5 is a complete tear of the subscap, which is gone beyond, retracted beyond glenoid, and there's a anterosuperior migration of the head. So how do I basically follow the treatment protocol? So I go with the Lafosse classification. There's a facet classification also, but I find usually very difficult to follow the facet classification. Along with subscap, there's always 99% of the time there's a biceps pathology. Some cases, yes, you will find a biceps normal. So biceps, if it is normal, along with its normal pulleys, which will usually happen in sometime in type 1 tears, or sometimes in very rarely in type 2 tears, then in that case, I leave it, because I personally believe one philosophy in the entire shoulder or knee: if a structure is completely normal, don't damage it, don't cut it. There's no point doing a biceps sternotomy if I find the pulley is normal or the bicep structure is completely normal. If biceps is abnormal, where it is flayed, split, subluxated, degenerated, or whatever, then you do the tenodesis or tenotomy as per the requirement of patient. So in type 1 tears, after you manage the biceps, I mean, whatever you have decided for biceps, I'm not going to discuss biceps. In type 1, we usually just do the debridement and leave it. Type 2, you can debride. You can use a single row repair with a single anchor. Type 3, again, you can use a single row repair with one anchor, and sometimes you might have to use a double anchor. Type 4, 5, I personally use a single row repair with 2 anchors, or some authors, they recommend the double row repair. So isolated subscap tear. Now we are talking about some situation where only subscap is torn, and some situation where subscap and supraspinatus along with the infra is torn. So if subscap alone is torn, you can repair the subscap from the glenohumeral joint. Before you place your anchor, you can actually go above. You go into the glenohumeral space and you can clean up the entire area anterior to the subscap, clean up the whole area, because that's where your anchors are going to come, where sutures are going to come. And it might be a little tricky to tie from front, so you can go to the subscap space. You finish your entire repair from the glenohumeral side, but when you come to tying, you can go to the subscap space and tie. But before that, it's important you would have cleared the whole space, because once the suture are in place, you cannot go in, put your shaver or radio frequency. So you can complete the repair from glenohumeral joint, or suture tying can be done from subacromial space as per your wish. Whereas if both are torn, it's fantastic, because you can use glenohumeral joints, subacromial space, and supraspinatus window to accomplish the repair. In case of subscap and supra, always repair. Here there's a tip. If the subscap and supra both are torn, always repair the subscap first to achieve the barrier reduction of the supraspinatus, because both are connected. Supra and subscap are connected at the front, which is where the comma sign forms. So you always repair the subscap first, bring it the whole thing, construct much more laterally. The supra and or infra repair becomes extremely easy. So this is what is the role of subscap repair in massive cuff tear. You can see here, this is a massive tear involving of the right shoulder, involving the subscap, supra, and infra. So initially it looks quite tricky. It may not be repairable, but as you continue to see, this is the whole video here. So this is where I'm going to hold the area where actually the comma sign is. The comma sign forms here. This is the place. So you hold this area where supra and subscap are connected. Never remove this connection. Always try to retain this connection. That's the part of the infraton. So what we do, we put a traction suture. That is what I love about subscap tears. I always put a traction suture at the apex or at the comma area. And then you try to pull and see whether you can reduce it without tension or not. Reduce, and then you repair with 1 or 2 anchors as per your wish. This is just the cleaning of the rotator and table. Once you have done that, you will get to see the MGHL. You will skip all that, not important. Then this is what is, you can see here now I have actually repaired the subscap. Once you repair the subscap, the same supra, you see it has come much more closer to the greater tuberosity. And then it becomes a far easier thing to repair this without tension, because we know any tissue in surgery we repair, it has to be tension-less repair. So, and this is how the final repair actually looks like. So the key always in these cases is first repair the subscap. And that's where when you do the mini open deltoid split, if you're not really cautious about the subscap, you will think that it is an irreparable tear. You will come out thinking that I could not repair, or repair the whole thing in a gross tension. Another just simple video to show that this is a left shoulder in lateral position. You can see it's torn, badly torn, retracted subscapular, almost type 4. And this is what happens when you apply the traction suture. See, when you pull, how the supra comes back to the footprint. Look how easy it will become. So you always repair the subscap first, and then go ahead and repair the, and then go ahead and repair the, so this is the subscap repaired in the same patient. And this is what is a single row repair of the supra and the infraspinatus, supraspinatus. Diagnostic tips. Anyway, I think JC will discuss detail about it. Always look actively for the subscap lesion, pull the biceps, check for the pulleys. You can see the anterior pulley and the posterior pulley. Look that if you're going to spare the biceps, is it normal? Is it worth sparing? Type 1 and especially type 2 and early type 3 are very hidden. Type 3, what you are thinking as actually type 1 could be type 3. So always have to, pull the arm backwards in extension and probably the introduction, then you can see the tear much better. I have, though I have a 70-degree scope, but I have never used it. Initially, I tried using once or twice, but I have given up. I am happy with my 30-degree scope. The way you want to see the subscap tear is best is to, you can push the, so you can push the arm backwards like this. If you push it backward, this area, it opens up, and what you feel as 2 will be actually sometimes 3. So always confirm the whole thing before you give up. So posterior push, internal rotation, and a bit of an arm inflection can give you a complete idea whether the subscap is torn or not, and don't leave it, because these patients continue to remain painful. Remember, subscap tear will hardly ever come to you with difficulty in elevation. They'll come to you with a pain. So I'm not going to discuss all this. This is how the type 1 tear looks like. We usually debride and leave. This is often you'll find a nodule here. This also just needs a debridement. If it exposes a bigger tear, you can repair it. This is the one which after the debridement look like. In sometimes this is my own philosophy, type 2 tear, if it is a very stiff shoulder and an elderly person who's 65, 70, I just leave it. I feel it's okay. You need not to do this. But if it's a non-stiff shoulder, I will always repair. Why in a stiff shoulder, I would usually leave it? Because stiff, if you repair, and if the repair is a little bit of tension, it's going to make it more stiff because you are tightening an anterior structure. I'll not go into this because this JC will clean up, discuss everything. So in type 5 or type 4, sometimes after you do the biceps tenotomy, if you feel so, apply the traction suture, thorough release. The retraction is so bad, sometimes you might have to do mini open. If in case you feel like that, this is irreparable, in those cases, maybe you require the pec major transfers. This discussion about the coracoplasty, now this remains, only with the Burkhardt and others. I think no one really could later prove that you really require to do the coracoplasty, because I also personally felt that because of the subscap tear, the head is actually migrated forwards. Since it is migrated forwards, the distance between the head, subscap and the coracoid process is reduced. So one feels like that there's an auroral ringer phenomena or the impingement, whereas it doesn't happen. Once you repair, once the whole thing is back, you really don't need to do the coracoplasty. It was never proven in many hands except one or two hands. Irreparable subscap tear, one can do the anterior capsular reconstruction described, but most of the time people do the LD or pec major transfer, and reverse if arthritis and other tendon tears are irreparable. If I have done a massive repair, especially supra, infra, and the subscap also was type 4. In type 4, sometimes I give this sling in a neutral rotation. So that keeps the arm in neutral rotation, because if you keep the arm in internal rotation in a classic sling, I always fear the internal rotation contracture or the, the tightness. So to get back the external rotation sometimes is very difficult for me. And for 6 to 12 weeks, I'll just initiate only passive range of motion for ER. Why I'm a bit more skeptical of subscap, because we realize in our own series You see, the supraspinatus tear and infraspinatus tear will come back to you if they are bigger tears with difficulty in elevation, whereas subscap tear will never come to you. I'll tell you the rate of re-tear are as high as something like 20 to 25%. But why they don't present? Because their problem is not the instability, or sorry, the elevation problem. Their problem is just the minor pain, and you will never figure out what's going on. So that's why the re-tears of subscap are common, especially if it's a 4 or a 5. So one has to repair it meticulously and do the adequate rehab, protect the repair, because the fibers of subscap are like that, and your sutures also almost in the same line. So if you've just done a simple repair, simple stitches in a hurry, the likely that is going to cut out. Thank you very much.
Vivek. So
Very nice.
yeah, so the presentation is open for discussion. Dr. Narvekar, Dr. Anta, Ranjit, Mukesh. Yes. Let me start the discussion, Vivek. Vivek, what makes you decide that this? Do you mean every subscap tear will need surgery, or you select your patient depending on the clinical presentation?
You see, are you talking about the isolated subscap or
Isolated subscap. When it is combined, yes, obviously you will always plan for a supraspinatus, but it's the isolated subscap tear. When do you decide for the surgery?
Okay, so Roshan, most of these isolated subscap tear, you can divide them in two categories, traumatic and degenerative. If it is traumatic, most of the time they are 3 or 4. And if you carefully remember, try to recollect their MRI or ultrasound report, in almost 70 to 80% cases, the biceps is subluxated. If the biceps is subluxated, it is going to act like an axe over the, the subscap, and they will continue to remain painful. So if it is a traumatic, whatever traumatic or degenerative, once the biceps is subluxated, it's hard that the pain will go. They will not give many major complaint, especially if he's a non-sports person. If he's a routine person, he will not have, because this internal rotation, when you check the belly press, all that, the lack of strength is not really felt, especially in the early type of tear, 1, 2, or 3. But the main problem comes from biceps. So I'll leave them for some time, couple of months. But if they keep coming, and they say, no, my pain is not going, then I'll repair. Type 4 in a younger patient, whether it is relatively younger, and this happens usually traumatic, I would not leave. 3 onwards, I would not leave. I'll say you get it done, because you will continue to remain in pain. Whereas in the elderly patients, you can leave and try. But 4 onwards, no, I would not. 4, I'll certainly repair, because they will not improve. They'll remain in painful. So not every, but 1 and 2 you can manage. 3, you have to be cautious. And
Hello. Yeah. So, Vishwadeep, you have any question for Vivek?
Yeah. So one thing is interesting in a way that he is trying to fix his post-operative cases. But what added advantage do you get in giving them in a neutral rotation? Because I per se don't keep them in internal rotation, in external rotation. Do you think it helps in gaining back the strength in subscap in post-operative phase? Is that on your mind, or is it just the stiffness per se that you keep them in external rotation?
Vishwadeep, my connection was lost for a while. Can you just repeat the question?
So I particularly I was looking at your post-op photograph, wherein you kept your arm in neutral rotation to almost external rotation. Am I right? So your purpose of keeping the position of this is entirely because is stiffness on your mind, or do you think that this helps you to better regain the strength of the subscap?
No, it's only the Vishwadeep, it's only the stiffness in mine, and that's only for the, you can say the, the so-called 3 nearing 4 or 4 onwards. I won't immobilize like this in, 2 or early 3. So it's only the stiffness which is in mine, not in the, because strength does not depend in which way you have immobilized. Not really.
Yeah, I have a question for Vivek as well as Dr. JC, if he can address this issue, because we have been taught about the anatomy and anatomical attachment of the subscapularis, and there has been a varied report how it gets attached and what are the function. When I saw your paper along with Dr. Youngalri, it says that it has got facet A, B, C, and D, which goes down up to the shaft, creating a complete hammock, the anterior and the inferior hammock, lifting the shoulder back. So do you mean to say that partial tears of subscapularis can be left alone with knowing the anatomy, that the superior part of subscap doesn't contribute to any of the high rise of a high amount of functional deficit? JC as well as Vivek, both.
Vivek, go first.
The anatomical
Roshan,
attachment. Yeah, I think Vivek's internet is not clean. JC, if you could
just
address.
change my, just a minute.
Yeah. JC?
Okay, so my point of view is that so the subscap or supra or infra, when you were young and when your shoulder is normal, it was all there attached. So once it's torn, that means that your function is decreasing. Maybe it's because of your age, maybe it's because of your trauma. So I think there is a role for every vector or every portion of your subscap. Do you hear me? And
Yeah, we can hear you. We can hear you.
and so I think it depends on the patient's activity and the patient's activity, the patient's needs. If it's a young patient, only 1/4 upper portion tear would give some discomfort, would give some problem. Whereas if it's 70-80-year-old who has supra tear with upper 1/3 tear, but it's balanced, maybe then 1/3 tear of that subscap might be less important. But I think it's all dependent. It's all dependent on who you're talking to and what their need and how they're functioning their shoulder. And you can see the F1, the F1 is more like a supra. So it's more like an abductor, less internal rotator. But as you know, if F1 has torn, usually there's some, my talk would be on anterior superior tear. So if F1 portion is torn, and then the supra portion is torn also, it's very, very highly likely they're kind of combined, which means their abduction capability as well as a little bit of rotation capability would be a problem. So I think, I don't know if that answers your questions, but
Yes.
it's usually, it depends on the situation.
Roshan, can I speak?
Yes.
Yeah. So regarding this your question, important thing is subscapularis upper 2/3 is tendinous part,
Yes.
and if out of this 2/3 part, 1/3 or 2/3 is complete tear or partial tear, like according to the studies of Burkhardt or Snyder, everybody we see, or the younger Reed, you need to repair it. What I feel like, because the most important thing is the tendinous part, which is giving the strength to the subscap. And if you are not repairing the upper 1/3 or 2/3, definitely that will just result will be just not up to mark. What I feel.
Is there any question to Vivek, or we should proceed with Dr. JC's talk? Dr. Narayana?
Can I,
Yes.
Roshan, can I ask one question? It's to Vivek. Vivek, there is a category of tears which in probably you didn't cover, you know it, but I would like to further try to ask you in terms of when you come across intact subscap, but you see that the tears are longitudinal tears are there in the tendinous portion, intra-articular tendinous portion. Do you commonly come across these? And if you come across, do you leave them?
His net is not working, it says.
I think Vivek's net is.
Yeah.
Net is not working.
Yeah, no, I have seen, but it's extremely rare, Vishwadeep. Very, very few cases I have seen, probably. So if they look significant, then I just, stitch them side to side. But they are in combination usually with the footprint tear. I have not come across a tear which is just a longitudinal split, whereas the footprint is intact. I have seen few cases, maybe in total 5 or 6, where the
Maybe-
footprint was also
maybe
torn
I'm not,
and avulsed, and that there's a longitudinal split.
I mean the tears along the parallel to the tendon which is coming onto the lesser trough.
Correct.
Interstitial tears.
No, that's what I'm saying. That's what I'm saying. So I have not come across only isolated those tears, but I have seen them in combination with footprint. So footprint is
I agree.
also gone, and then you have a longitudinal split like this.
Yeah.
So I usually repair them, in along with the footprint, and then if I feel that split still the split is open, you can always put one side to side stitch.
Okay. So in terms of these longitudinal split, maybe JC can tell us more about it.
Well, the longitudinal split, I think initially when I first started shoulder, longitudinal split meant something, but I think it's more of my type 1 subscap tear, and then it spreads up and it opens up the faucet. And that longitudinal split, I'll talk about this in my hidden lesion. It communicates with the hidden lesion also. So,
Okay.
So I think it's very, very, so I don't think you need to really do a side to side, what I usually do initially, but I think it's more of how much footprint is exposed with this longitudinal split. And I want you to, I don't know, some of you, if you don't look them really carefully, I think it's a little bit difficult to understand this, but usually I think it's very important issue on this longitudinal split and then going on.
Yeah, JC, I agree, because the subscap tear as such, they happen from inside out, unlike the other tendinous portion. I think Jong-Ho Kim has published from Korea in his subscap footprint work, and I think your name is also there in that paper, if I'm right, is that the subscap tears, if they happen from inside out, then probably some of these tears, they also travel along the longitudinal axis, and if you debride them at the footprint, you can further see that the tear is somewhere connected. But I happen to come across few patients wherein the footprint was intact, and there is a category of tears which in the tendinous portion, either it's just maybe it's just in the tendinous portion, but I found that the footprint is intact, but the tendon is little in a splitty way. But maybe you can describe more in your talk.
Yeah, I'll talk about that. I'll talk about that communication.
Yes. I think there is a question from Dr. Nicholas Antau. Can you hear me, Dr. Antau? Nicholas Antau? Can you hear me? I think he wants to ask some question, Dr. Nicholas Antau. He had put a question on YouTube also. So, Dr. Antau? We can't hear Dr. Antau, so I think we need to upgrade his software. Okay, we'll proceed with the Dr. JCU's next talk. JC?
Yeah, I can hear you.
Yeah, please proceed with your next talk, JC.
Okay, I'll do it.
We have few questions on YouTube channel also. We'll take them in the end so that we can have enough time for discussion. So JC is going to speak on management protocol for full thickness subscap tear.
Okay, wait. I don't.
Open your presentation in desktop first, and then
Yeah,
share your screen.
Oh, I found it.
Yeah.
Okay, so I changed the topic a little to talk about the anterior superior tear, which is more common than the just isolated. As you know, the anterior superior tear is subscap tendon isolated, or subscap tendon is isolated, or it's an anterior superior tear where it's combined with supra or an infra. And I'd like to talk about what I've been doing for past 10 years. As you know, in 2002, the literature say that it was a forgotten tendon, and it's almost 20 years. And I think Now it's just one of the most hot topic. One of the reasons that it was forgotten was that those big names like this Codman or Gerber, or these patients reported only like 16 cases, 7 cases, and so everybody thought that, wow, it's like only 3% out of 200. It's very small. But this is usually they reported large isolated subscap tears, I think. And I think the best recently we've been using a lot of this classification by Collins, and as you know, there are a lot of people with this figure in our thing, and just my my like 6 months cases out of 200 cases, 30% is anterior, 40% is posterior, superior, so it's pretty much same number, and you can see that, you know, with this kind of MRI, what this means is that you're going to have a long hours in your OR, especially if it's a left shoulder and you're right dominant surgeon. So if you're left-handed surgeon or if you're bidextral, you're lucky, and you have the potential or factor to be the best. You have a good surgeon, and a lot of good surgeons actually are. You can use both hands, especially in arthroscopic surgery. And so what this means, if you miss subscap tendon in long term, this is a 59-year-old male who visited in 2009 one of the university hospital with this MRI. And I don't know if you can see it, but of course you can see the tear on the supra, but then there is some fishy sign right up here. And if you can see this, and then that means, and if you see this, you can kind of see that there was a tear. And I think at that time, even 10 years ago, a lot of surgeons missed this subscap tears right there. And after 2 years, 2 years and 7 years and 9 years, this is what happens if you miss that subscap tears. So this is the long-term duration of this patient without surgery. And with the supra, it's repaired, and so supra, the volume is still maintained there. So I think we should focus on anterior superior tear, and I think the AB is almost same as CD, a DC, and we're very interested in especially A and C. This is very, very common tears. And of course, we can easily find this tears. And this is, see, you can see, you could call this a longitudinal split in between. You can see the longitudinal split in between, but this is actually opening up the faucet. And this can easily be diagnosis. The diagnosis is very crucial. Everybody knows this. Everybody, so Vivek talked about the physical exam already, but I want to tell you that the bear hug 2 positive or belly press is usually upper 1/3 tear, whereas if you have the lift off test positive, it's usually more than 1/3 tear. So that is the key sign there, and the X-ray, although a lot of people kind of forget about the X-ray, this is what you can see, that the X-ray from this part and the other side is a little bit different. You can see the irregularity and sclerosis, and you can kind of detect whether there is a tear or not. And if you have a large tear, it's usually easy to diagnose. But if you have a small tear or less than 1/3 tear, that's the first faucet, and you can see that there is a void sign here. So if you're looking for the leading edge tear, you really have to look for something else. And this is our paper published in 2016, looking at the first faucet view. So there's a lot of things going in there, but just looking at the conclusion, the first faucet view should be looked at in your sagittal oblique view and see where that void sign is, and match it with your your scope finding. And the first faucet view of sagittal oblique view can detect about 70% or more, slightly more. So that's what you can expect. And and we recently published another MRI view on Costa looking at the coracoid and baseline view, and with the tangent view, looking at these two more views. This is on-face view and Y view. And on-face view, you can detect about 1/4 to 1/3 tear. Y view, you can detect about 1/3 or greater tear. So the whole thing is inside my paper, so you can just kind of get the glimpse that there are some valuable things that you can look for with these two views. Before we go further, I want you to know the acute on chronic cases, because subscap tear have a lot of acute on chronic cases. And usually massive tear becomes when you fall down on a slight minor trauma. And usually it goes this way or it goes this way. So this is acute on chronic tear. And this is, if this is a very typical, but you don't often see this a lot unless you scope them very early. You can see this bruise and tendinous portion. This is an acute chronic tears. And usually they're combined with frozen shoulder when they appear to you, because it's after trauma, about 3 months later, there's a frozen shoulder. And you can see that the acute on chronic tear have this typical finding of this subscap, and in young patients, especially 40s or 50s, they have this acute on chronic tears and isolated, and they're very easy to reduce and repair. So I think you should be focused on seeing this acute tears. And then their results are really good if you repair them very early, and then their motion is very good also. But you know, the belly press and bell hug sign is usually not that recovered early, and sometimes they don't recover as up to the level they had before. And so the most commonly involved anterior superior tear is 1/4 to 1/4 tear, leading edge tear. I think as Vivek mentioned about this this footprint study, but this footprint study is not right. This footprint study that I'm sorry, but the Burkhardt and Richard, one of the famous names, but it's not. This is just only looking at the first two faucets. So this is the state of Nevada, but I think that's wrong. But more likely, it's a comma sign. It's like a comma shape, and this kind of appears with our study, looking at this kind of comma shape with the first with 3 or 4 different faucet with 3D perspective. And this first faucet is the most largest faucet, which is 34%. And the first faucet is about 14 millimeters times 14, depending on the size of the patient. And usually, the reason I want you to focus on this faucet is because it gives you an idea which one to repair and maybe which one we shouldn't repair. I know Vivek like LaFosse and everybody like LaFosse, and I don't have that big name, so it's not as popular. But if I was born in USA, it would be a little bit more popular. That was a joke. But anyway, this is the first faucet, and if it's less or more, if it's entire, I think that's what we want to be focused on. And actually, if you're experienced as much as Vivek, I think you can easily catch up this. It takes a little bit of time for beginners, but this is the second faucet right here. The first faucet is from the pulley. So this is like less than 1/3 tear. The pulley is right here. And is everyone seeing the video okay? Anyway.
Yes, we can see it. No problem.
Okay, and then this is the first faucet here with the lateral portion. You can see right here, the dark place here, it's opened up, which means this is becoming a complete tear of the first faucet, which is type 2B. And then if you lose the entire lateral portion, then it becomes the entire first faucet right here. So that's 1/3. And then in type 4, I want you to be looking at the chronic and acute on chronic types, because this is very important in determining a repairability. Although it looks very, very large, some are easily repaired, not easily, but some are repairable. Whereas like this case here, This is a large chronic tears, and you detach everything with the all the adhesion from the coracoid right here. You can see all the adhesions right there, and that's the conjoined tendon. You can see the conjoined tendon is already frayed. I didn't make this fraying. This patient has been impinging on that conjoined tendon, and I usually don't do crocoplasty, but just some people are very close, very, very narrow. So I like to do right there. You can see that that's the first facet, entire first facet is exposed right there, And but you can see that how much tension I give with that traction stitch, it's still, I cannot get it to the footprint covered. And some large chronic tears also have this V-shaped tear. I don't know if you understand this V-shaped tear. If you understand this V-split tear, you're a very, very highly experienced surgeon of this subscap. You have the lower portion here, and you have the upper portion of the tear with the comma sign continuity. And this is a V-shaped tear. And this is the communication of that intraarticular and extraarticular, which I'll show you later with the hidden lesion. And well, let's skip the hidden lesion because I think I have a whole section of this. So I'll go straight to the repairing techniques. And so this is 2A. Right there is the footprint opened. This might be too large. So this is a concept. I want you to think about this concept. I'm not giving you an answer. This is not an answer. 14 times 14. That's how big that faucet is. So maybe if the faucet is big enough, then you can have that anchor somewhere there. I'm not saying you're gonna have 3 anchors. I'm saying that you can have it anywhere here. And then if you have the big tear, like if the entire first faucet is exposed, and then you want to know how you're going to repair this. This is my construct usually because the first faucet here and second here, so you can put your anchor and do a double row. You can look up our techniques there. We just had from Yonggol Lee with our 2-center study, our result of isolated tears. We have our mattress repair technique. In a single row mattress technique. I just kind of modify this to do a double row technique now. I'm more favored to doing double row with supra and infra and subscap also, whenever it's possible. And the repair technique should be, in my hand, divided into 3 different categories. First is to do intraarticular, all inside technique, or you can do intraarticular with the subacromial out of the box procedure and completely out of the box procedure. As you can see, there is small intraarticular tear. I told you there's a faucet is exposed here, right here, and then we can do an intraarticular all inside repair like this. You can see there, IA tear, another. You can see, or you can do our combined technique, go upstairs, you repair here, and then you can see that it looks like this. When it's a large tear, you can see this right here. There's a split, but when a large tear, the leading edge is usually, where's the leading edge? When I first began doing surgery, I didn't know where the leading edge was for the large tears, but this is the comma sign right here. This is the comma sign, and the leading edge is below the glenoid. So leading edge, once you get rid of this tissue here, it's below. And of course, you have to look for all that adhesions that I told you before. You can see that large tears, there's no way you can approach without doing the comma, leading edge, and doing the release here. So I think you need to do out of the box procedure for all the large tears. And then this is the pectoralis major right here inserting. And that's the tissue there. Right here is the first faucet right here. That's the first faucet. And then below that is the second faucet right here. That's the second faucet, pec major insertion. So you can see the two facet easily, and this is a large, more than 2/3, more than 1/2 tear. There are limitations. So this is a burst approach mainly. I'll skip that. There are limitations. What you see is what you know, an MRI Y view. Sometimes, like what you see this, it's repairable. Sometimes this maybe not repairable in my hands, so I did pec major transfer. But the limitation, I guess, it's just, it has to be up to your hand. I mostly repair subscap. I rarely do pec major. I think I do less than 1 or 2. I see a lot of subscap tears in my clinic, but I do less than 1 or 2 a year. So that's very limited. And so I cover a lot of things. I will cover the hidden lesion in my second talk, but this would be my a summary, and I prefer double row in this. Thank you.
Thank you very much, Dr. JCU. That is a wonderful talk on subscapularis. So I think many of us are going to have some of the other questions for Dr. JC. Anybody has a question? Dr. Antav, can you hear us? Dr. Antav, Dr. Nabhay Narvekar, Samir Sheikh. Yeah.
So what,
Mukesh, yes.
sir, what is the preferred anchor choice then? Smaller, less than 5.5
Mukesh.
or all switching? Yeah. Yeah, sir.
Mukesh,
Yes, professor.
He's asking what is the choice of anchor?
Small
Jesse.
size.
choice of anchors. Usually I use for rotator cuff, large tears. I mean, small tears with hard bone men, you can use whatever anchors you want. It doesn't really matter. But for large tears, women, if they've been sick for a while, so that means the proximal humerus bone is already very osteopenic. So I think in that situations, I use the largest anchor you have, usually 5.5, more medial. So usually if you go very close to the cartilage for the supra and very close to the subscap, like same as in subscap, that too.
In young patients, what you do for biceps stenosis, where you do it?
Bicep tendon, I do a sub pec. I do supra pec. So right, supra pec.
By suture anchor?
Oh yes, I do it from suture anchor.
JC, how important? JC, how important is it to match the tear to the facet? Because very often you could have a more distal tear which is repaired on to facet 2 or close to facet 1. How does it affect the function eventually?
Very good question, but usually most of them you can repair up to a lower portion of facet 1 for a chronic large tears. Very rare that it doesn't come to the first facet and you have to repair to the second facet. But I'm sure there are cases. The cases I see usually come very early, I think, compared to some other regions where the patient, they don't do any treatment to their cuff until it becomes really, really massive.
Jesse, when you say that the superior facet is the most important and then the second facet is the second most important, but do you see the amount of retraction always depends on which facet tissue is retracted, and commonly it is a superior and the F1 and F2 facet which gets retracted, whereas F3, F3 they stay back. So what is the force which is required to get back that retracted tissue onto the facet, and do you do a coracoplasty? You think the
coracoplasty, I do. First, I will answer that.
You think the importance of facet with respect to the coracoid Is it a cause for retraction of the tissue beyond coracoid, or it goes up to the coracoid? Because only two facets which get damaged.
Um, no, it's not damage. It's just usually when the first two facets is involved, that means it's a 2/3 tear, and it's like almost the entire lesser tuberosity tear. So that's the biggest tear that, other than if you have the muscular portion tear combined, which it means complete tear. But I think usually there is not that much of that tears. So when the first two facet is exposed, that means that you are dealing with a large tear, and you might want to think of whether I can repair it. Should I repair it with mini open, or should I do a pec major transfer or a lat dorsi transfer? Usually the first two facet is not that exposed. Usually the first facet is exposed completely, and the second facet is covered when you try to do a repair.
Second question, Jesse, is often the subscap tendon tear are usually the very, the tissue which gets retracted is very lousy. It's not very, you don't see the same tissue what you are seeing in supraspinatus. I don't know. Some of the subscap tears are associated with the not a very good tissue quality as compared to the supra or infraspinatus tissue. So how do you manage those very bad quality tissue? Do you have a special suturing technique, or you do what?
No, I don't have any I think it's just depend on the patient. Luckily, most of the patients I have had relatively good tissue to repair. But like you said, if there is a patient with the poor tissue, I don't think we can do anything much with this patients. And I think you start thinking, if it's an old age, I do reverse. I sometimes do reverse right away. I try that for a couple of times. I go in, try to repair subscap or large, massive supra infra tears. If I cannot mobilize them, and if they're old enough, which is means 65 or 70, I just go right to the reverse. Otherwise, if they're young, I think you should try to do some transfer if you are comfortable with doing transfers. But if you have a poor tissue, I don't think that's your fault.
Oh.
I don't think you can do anything about that.
Okay. Any
in your repairing technique, JC, do you maintain the comma fully, partially, or you completely release it?
No, you
And
definitely you definitely don't have to touch anything with the comma. You detach it from the coracoid base. That's the key technique. Like, it's the key technique for not only subscap, but it's a key technique for the supraspinatus massive tears, large tears. And you detach it from the coracoid base to the CHL undersurface towards the glenoid tubercle, and you detach underneath, and you keep the comma. And you don't need to cut it, because that's the maximum mobilization you get with the anterior portion of there. So I don't cut anything.
Okay.
JC, I would like to ask you one question.
Yes.
I would like to ask JC a question regarding his, if he has come across athletic population, especially contact athlete, who have a complete subscap tear, so-called. And how satisfied are these patients when they go back to the same level of sports? Do you think their internal rotation strength is maintained?
Oh, I think I don't have that much experience with the high context like rugby. We don't have rugby in Korea. Well, there is, but not many people really play. The only heavy sports would be soccer, but I haven't seen really like a massive tear in subscap tear in this high. But I think this patient is an acute tear. If you catch them early enough, their tissue they're young, they're acute, and these two components is the best component. I think you can repair them, whether it's open or whether it's arthroscopic or whether it's mini open or open. I think if you repair them sufficiently at the proper spot, I think they will function okay. But if they're chronic and they're very poor tissue, which is very rare in these patients, I think, then that's not, I don't think we can do anything about them to be back on whatever they are trying to do.
So my particular reason for asking you is that how satisfied are you of the younger patients whom you have repaired your
Oh,
subscap?
they're
I
much
mean the large tears, and in
they're
terms
much
of their
they're much satisfied because they're usually young patients are usually acute tears, acute and chronic tears.
okay.
There are no chronic young. There. I mean, they could be, but usually it's not a chronic young patient. It's chronic older patients. So
Okay.
the tissues are much better.
Okay.
That's
How
my
often? Yeah. Okay. My second question to you is that when you are doing from the subacromial space and these are larger tears, how often do you actually make an effort to see the axillary nerves
I always
of these?
I always look at the axillary nerve.
You
It's
always.
yeah, because it's almost always because it's right there, and you don't.
Do you make any efforts to say if there's a chronic retracted tear, do you have in your mind that if you're going to bring all the tear back to the footprint, there's going to be any issues, neurological issues? Do you do
No, no,
anything
no.
to?
I don't think there is a neurological issue. It's just that when there's a large retracted, it's closer than you think. And actually, you don't have to be too scared of looking for it because it's still
Yeah, it's
far
right there.
away.
Yeah.
It's right there, but it's still far away. And I always look at it because there is a very thin. There's a very thin capsule or bursa tissue, whatever you call it, and you just remove that, and it's right there. So I look for it, and then I try to make my stitch in front of that, so try to avoid any possible. If you do it blindly, it's like my humerus shaft fractures. I was 15 years ago. I did a humerus shaft fracture blindly without looking for the radial nerve, and then one of our fellows kind of severed the nerve. From then on, I've been looking when I'm doing a humerus shaft fractures. I always look for radial nerve first. I look at it and then I protect it and then do my fracture surgery. I think it's the same principle that if you doing a subscap, um, just it's right there.
Right.
Look for it and then you can just avoid it doing anything to that nerve. Okay.
Any
So
other question?
Basically,
Yeah.
Yes, yes.
yeah.
let's go on with my second talk or
Yeah.
No, there is one
I'm
more
sh-
question. Vivek, you
Yeah,
want
Jason.
to? Yes.
Hello.
yeah, go ahead.
Yeah, JC, very elegant presentation. And I just few comments to make. One, I completely agree that I do not agree with that Nevada thing because actually one slide I removed and that was your whole facet thing. Okay.
Mhm.
And after that, the Sugaya and other studies also said it's almost like a big comma.
Yeah.
Okay. It doesn't fit into the Nevada sign does not fit into the dimensions which are actually described for the subscap, which is completely agreeable. Second is, I think I mean, we have read your paper couple of times, and probably it is the visual impression classifying it very easy, superior third, probably superior two third, and full thickness tear has made us very easy, just to do that. But I completely agree that if we start making an attempt to identify the facet, and see where exactly it is, maybe sometime I need to come to Korea and
No, I
we
think. Are
understand.
you doing beach chair or lateral?
JC, I do it in everything in lateral.
Okay, so then you'll be easier for you because beach chair people are more confused.
Yeah, lateral is very easy. Lateral, you just push your shoulder behind and flex it. You'll be able to see a complete.
Rosen, it's easy for you, but it's not easy for some people.
I'll learn it for you. Don't worry.
All right, and so let's go on with my second talk, and because it's already almost 9 o'clock
So
here.
Jesse, how often you miss subscapter in your clinical practice?
What do you mean by miss?
Miss, you're unable to diagnose it. You diagnose it
The
on table.
subscap master. You are saying you're talking of a subscap master with multiple publications, and you say how often you miss it.
No, but clinically, is it possible to miss subscapter because you may not give that attention on subscap, and many times, especially in India, when we are dealing rotator cuff on the table, we realize that this patient has a subscap tear.
Adding to this, to Roshan's question is, if we clinically don't find any upper 1/3 or mild subscap tear also, and when you go in and you find that there is upper one facet tear along with supra, so do something to subscap or just leave it. Consider it's a 60-65-year-old male or female.
Mukesh,
Jesse.
it was, I didn't hear the first part of your question. Sorry, I was looking at something.
Dr. Roshan Wade was asking ki if how much chances are there to clinically miss subscap tear, and secondly, adding to it, if clinically subscap is, we didn't find clinical diagnosis of subcap, but intra-op you find a upper 1/3 or 1/4 or some first facet tear, but clinically patient didn't have any signs of subscap tear, so you still go and repair subscap, you just debride it and repair supraspinatus and come.
Well, that's a very good question, but I don't think I will have the answer for that. But what I would do is that I miss subscap tear. I have a very high definition or high quality MRI most of the time, and I miss subscap among that with that MRI about 20 to 30%, I think. Or I overdiagnose it. Sometimes I overdiagnose it that I think there is a subscap tear, and then I go in, there isn't. So there's another issue because of this small tear that we're looking for, the small upper 1/3, 1/4 lesion. And whether to repair or not, that would be like, I don't know if we can answer that question in my lifetime, but because people are so different and their demand are different, age is different. I repair 1/4, only 1/4 tear for a 41-year-old who the supra is okay, but has pain and has subscap symptoms, and it's only 1/4 tear, it's very small tear, I repair that. But if it's like 70-year-old with supra and infra tear, I repair, but I coincidentally find like 1/3 tear, I might just maybe leave it alone. But nowadays I try to repair a type 2B, which is more than 1/4 tear in almost most of the patients that I encounter. I try to neglect 1/4 or less tear for most of the patients, unless it's the primary reason I went in to do surgery for. So I don't know if that answer, but that's it's a very difficult question, and there's no answer. That's current practice that I've been doing, and I've been doing this for about 5, maybe more than 5 years, and I haven't changed my thought yet. The only thought that I have changed is that I try to repair 1/4 to 1/3 tear more intra-articularly, whereas I used to do more out-of-the-box repairs, because out-of-the-box repair, I think, gives more tension than in-box repairs or intra-articular repairs. I don't know if you agree or understand that.
Jesse, if you have to repair the facet 1 and facet 2, the superior and the middle facet, so in that situation, will you do a single row type of single anchor repair, or will you do a double row, dual row repair?
Well, I think the issue of single row, double row is that if you can cover the footprint, I usually try to do double row. If you cannot cover the footprint, then it automatically becomes a single row repair. Whether you use an augment lateral row anchor or not, that's not true double row. That's just force distributing a lateral row augment or tension. Like if you repair the medial and then it doesn't cover the GT or it doesn't cover the LT, then if you put another anchor at the lateral row, that's just retensioning. It's not a double row repair. So your answer has to be whether if you can cover the tuberosity or not, if the tissue is sufficient enough to cover that tuberosity.
Okay. Anybody has a question before we
I'm
move
sure
on to
they
the
have
next?
like
Yes,
tons of questions.
Yes. Okay, we'll move on to the next talk. Jesse.
Okay, I'll talk about the hidden lesion.
Hidden lesions, yes.
And
I'll just mute everyone. Just give me a time, and please don't use the presenter's view, because presenter's view will not be seen best in the YouTube.
Which one?
I think you have a presenter's view, Jesse. Okay, no problem. You can go ahead. Yeah, you can start, Jesse.
Okay. So wait, let me see. I'm on a presentation view. What? See, I have two monitors. I don't know if that's
Yeah. No
that's
problem. You can go ahead.
Wait. Where's my first slide? Sorry.
Now in the PPT, JC, there's on when you say presentation, there's a presenter's view. If you unclick, it will show you only single screen.
So where is it? In the slideshow?
Yours is in Korean, so we can't understand.
Yeah, in the slideshow. Yes, click on the slideshow.
Click on the slideshow.
Slideshow.
Mm-hmm. And where?
You unclick the
Oh, okay. I got it.
presenter view. Okay.
Is that better?
Just start the
Now
presentation.
you share the slides.
I think I shared the slides. Wait,
No, slideshow.
let me do this. Let me do this. Wait.
Perfect.
Okay, well, this is not this one. Is that better?
Yes. We can see and hear.
Wait. I'm having some trouble with this. Okay. Is that okay?
Yes.
No, there is something covering on your screen on the left-hand side. You need to close that. Something is covering. Yeah.
Something is. Well, let me see. Let me just close everything. Is that working?
Yes. But there is something coming on the screen. I think your desktop something is open.
I didn't open up anything, but everything's closed right now.
Sandeep?
There is some gray color bar coming in the bottom of your presentation.
Because
I
Dr.
think
You just unshare the screen and share it again. Share only
Okay.
PowerPoint, just PowerPoint.
Okay. Hello?
Yeah. We are seeing your video.
Well, something just stopped.
So what you do is whatever presentation you had, you just open in desktop and then share that presentation in the Zoom.
But you guys,
So click on the green tab, share screen.
I know, but the whole computer just went down. I think I have to come back again. So please talk.
Yeah. Okay. Meanwhile, we'll just ask the experience of Dr. Vivek, Dr. Narvekar, Dr. Antav, Mukesh on subscapularis. Dr. Narvekar, what you do double row or single row subscapularis repair?
Single row.
Single row.
I
Vivek?
do single row.
Vivek?
No, only single row. But I think JC was right to say, see, I personally felt that area is not so huge enough to actually do the real double row. So you
Okay.
saw me putting that traction suture. So what I do, I retain that traction suture for a long time. Okay. Till my entire repair is over. And most of the time they are anterior here. So I use that same traction suture to put it in one of the footprint anchors along with the supraspinatus, just to redistribute the load. So I personally don't do it.
Double, single row. Samir?
Single row 95%. In 5% cases, if it's coming up to footprint, I do double row.
Okay. Mukesh?
Single row only, but I don't know the question which Roshan asked. If it's a first two facet tear, then you use two anchors or you repair it with single anchor,
Single
even
anchor,
if you do
whatever.
single row.
That's true. So you use two anchor or do a
No,
single row?
I do single anchor repair,
Single
even
anchor.
if it's two facet tear. What else other do?
So I always do two anchor repair, and if possible I do double row also. So sometimes if I'm doing a subscap tear, I may end up using either 3 or 4 anchors only for subscap. So it depends on the quality of tissue and the type of tear. If it is involving facet 1, facet 2, then I always do a double row repair.
But that's if it's isolated.
Isolated, yeah.
But if it's combined, then single row.
Single row. If it is a rotator cuff and subscapularis tear, then you have to do a single row because you cannot afford that much of anchor. It's very difficult.
Space is also not there.
How many of you do a partial debridement for a partial tear, Vivek? I think in your presentation you told about the debridement about the subscapularis tear, the partial tears of subscapularis. Do you do only just debridement or you always do a repair? Can you enlighten?
That's what I think JC was also telling. You see, type 1, I just divide in most of the areas. I don't touch them. Type 2, if he's an elderly, about 65, closing to 70, and we are doing a cuff, and it is, you know that it's not really big. I sometimes leave them after biceps tenotomy. But is a younger one, 55, 60, then I'll probably place the anterior most supraspinatus in such a way I'll take the bicep from there. Or if I'm doing biceps tenotomy, so it's remains a bit more, flexible. No hard and fast rule. Depends upon age, want, stiffness. If there's a stiffness and all, then sometimes leave type 2.
So at what time you decide to do a bicep tenodesis along with subscapularis tear? Vivek, Abhay Narvekar, Samir Sheikh, at what level you decide to do a tenodesis along with subscap repair, the bicep tenodesis?
So I always do it at a juxta-articular level, just using a suture anchor.
Okay.
I have never done just in isolated biceps, which it has gone out of the articular side and it has been outside the articular surface. Then only I go and do a subpectoral tenodesis. Otherwise, always juxta-articular at present I have done.
Vivek, Mukesh, Dr. Narvekar.
I always do tenotomy.
Tenotomy. Vivek.
Again, depends upon case to case, Roshan. If the intra-grooval part of the biceps seems to be a bit healthy, then I do, supra groove only. Okay. But if I feel that the groove component is also showing a lot of sinusoinoitis, then I'll go subpectoral, do it open.
Dr. Narvekar, when you decide to do tenodesis or tenotomy?
Mostly tenotomy only.
Mostly tenotomy. And Dr. Anta? Okay, I think Dr. Anta cannot hear us. Jesse, are you ready with your laptop?
Yeah, I'm ready.
Yeah, can you share the screen?
Yeah, I'll share.
Just open the presentation.
Yeah.
And then share the screen.
Okay.
Okay. So I'll just mute everyone, Jesse.
Okay, now it's better, right?
Yeah, yes, you can go ahead.
So, can you hear me?
Yes, we can hear you and we can see your presentation.
Okay, so the concealed lesion is not, this is a no-brainer, but it's not easy to detect. And this is why it's concealed and high suspicion is needed. And in our study about that faucet, we already mentioned about 50% is torn. And we already mentioned this concealed lesion right here, and it could exist anywhere in type 1, 2, and 2, 1 and 2, 2A or 2B. And the concealed lesion, I just named this. It could be any name. I don't know. It doesn't have to be this name, but I just concealed intratendinous subscap tendon tear, and it usually occurs right here, where that portion, and it expands like this. And what I meant before by the V-shaped tear is that the tear extension go this way and then go this way. So so it could be anything like concealed here. And as you can see, I told you about the first faucet view right here, and that's very important. And this is a very interesting thing, is that you can see there's a little small there's a small like longitudinal fibrillation right there, right? And you can see that this is not big tear. MRI doesn't show any big changes. And then this is type 2B, and both of them also go like this, and then it communicates like that. And this is already seen. You can see that longitudinal tear is not actually longitudinal, it's a footprint opening right here. You can see that this is a longitudinal, but it's opening up here. And MRI sometimes is, like I said, MRI is not really definite, and I kind of get fooled on this. Sometimes you're lucky, you might see like that, but like those. And I showed you this before, and that's 2A. And then it could happen anywhere. As you can see that this is opening up. You open up here right there. And to visualize, the first faucet is up here and like this, going up that way. So this is a very small opening there. And you can see the communication from here to that first faucet, and from that here, the lateral hood disruption. And this is 2B. I showed you this before, so I'll skip that. But in many young patients, with the anterior shoulder pain, especially where the groove is, the groove, and usually it was considered tendinitis, right? But I think it's not tendinitis anymore. We've seen all this, but if he has a chronic pain, especially biceps area, it's more likely to be this partial tear with instability. And some of them are extreme like this, but you can see that this could be painful shoulder. And then our textbooks say that biceps tear is right here. If it's greater than here, this textbook or this thing. But what about less than 50%, like small tear like this? You can see if this patient right here, his biceps is subluxated right there, right? You can see that it's way inside the biceps subscap. And so that's subluxation. This is easy to diagnose. But what about this case right here? The one I showed you, there's a small tear here. There's a small tear here. So what are you going to do about that? Is that a bicep tendinitis diagnosed? You can see that the medial side of their fraying is slightly more than you think, right? So what do you do? So let's go back to this patient. This patient gets a small tear there. But if you go upstairs or out of the box, first you cut the bicipital, the cover of the biceps. You can see there's a small hole here, right there. You can see that there's a small hole there. That's the communicating, the communicating. It's more lateral than medial, so it's hard to detect on that. And the biceps was communicating with that. The biceps is communicating with that. And so I call this concealed intertendous tear. And it could be anywhere. It could be anywhere within this tear. And this is a very typical concealed lesion. You can see there's a medial fraying of the biceps. There's a small tear. There's a small tear here. It becomes a little bit larger once you have debrided little. It becomes this large once you debride it. And 70-degree scope sometimes helps, but you can see that it's only longitudinal split right there. But if you go upstairs, do the tenotomy or tenodesis, whatever you want to do, get rid of that biceps. Get rid of that biceps, and then you cut that interval tissue. You can see this is even larger size of what you saw. You can see that there's right there's a tear right there. That's where the biceps was subluxating, and it's communicating. It communicates towards the intraarticular. And this tear, if it goes downside this way, if it goes this way, then it becomes a V-shaped tears. If it goes this way, if it goes that way, then it becomes intraarticular subluxated tear, which we see sometimes commonly. So this is a very typical the cyst lesion. And so biceps tendinitis, I think a lot of them are usually this, and you can see many different shapes, this shape, this shape, this shape, and even communicating like that with big shape. And of course, sometimes you can easily see it on MRI with the subluxation. If you see it in supra tears, it's easier. Usually biceps tendon is unstable. So the key finding is that the biceps subscapularis is framed. This is the key pathognomic sign. If you find that, you almost have this lesion. And we recently put a 10-point scale for this score, and we just published this with the hidden lesion, concealed lesion. We just published this in OJSM, so it will be coming out this year or maybe next. And it's the scoring system is all there, and you can kind of tell whether it's out of 10 points. And if you have 7 points, you can kind of suspect this. It's not perfect, but you can suspect this. So in summary, the occult lesion, cyst lesion, and you can have all this tears, and that's it. So
Thank you, Jesse, for a wonderful talk on concealed as well as occult hidden lesion. Anybody has a question? Dr. Narvekar, Dr. Anta, Dr. Vivek, Vishwadeep, Samir. Yes, you can unmute yourself and you can ask question about. Let me ask Jesse about this concealed lesion. What is the usual clinical presentation for this concealed lesion? How do they present?
Usually they have pain anterior, or many of them, or they have pain and an internal rotating work, like supposedly reaching out the back, or maybe reaching out the other side of the arm, or it's not a constant pain. They never have like constant pain. They have a sleep disturbance. They don't have these kind of, they usually don't. I don't know, they might have, but usually they don't have sleep disturbance. It's not a constant pain. It's usually a positional pain, and they're usually young, and you just have to have high suspicion. The high suspicion is the only tool to look at this. I've been doing a study of this cyst score, and if you look at these couple of things in your MRI and a physical examination, you can kind of have like a high suspicion of this lesion, but it's not that common. It's not like you find it every day or something, but it's surprisingly there are quite more than you think.
Second thing is when you see this kind of concealed lesion, similar. Do you think these are the similar way of intratendinous lesion what we see in supraspinatus, or this is a completely different etiology? And how does the management change between supraspinatus intratendinous tears and the concealed lesion of subscapularis?
Well, I think the reason of this tear occurs is mainly due to biceps. So I think it's a little bit different from the supra intratendinous tear. This tendon is, I named it as intratendinous, but it could be slightly more bursa tear. It goes in towards the mid portion of the subscap. That's why I call it intratendinous. By the subscap is rubbing towards that tendon, that medial wall. But I think it could be called some other names, but I think it's different from the supra-intratendinous tear. This is caused by biceps. So the biceps is the main problem, and if you get rid of that biceps, you might not even have to repair this tear once the biceps is not damaging the subscap.
Roshan, I have a
Yes.
question.
Yes.
How
Vishnu.
different is this from the medial pulley avulsions or tears that you?
Well, the medial pulley aversion, medial pulley tear is going towards more medial. This is more lateral. I don't know if you understand, but the biceps goes in towards the groove, towards the intraarticular from lateral to medial side, and the pulley lesion is usually medial, intraarticular, and you can kind of find this thing going on with this a tear. Whereas this thing, if you go in as a scope, you can't see it unless you have a high suspicion. If you can see it inside, that means that's already the pulley is gone, and then that's an intraarticular communicated subluxation of the biceps from the inside already. So that's a little bit different from this, what I'm trying to say is a hidden lesion. Intraarticular side tears are easy to diagnose because you already are you're scoping right inside.
Any, can I ask a question?
Yes. Yes.
Yeah. Any particular category of athletes or patients you think we should keep a high suspicion to find this kind of lesion?
Like I said, the only thing, well, that's a good question, but I haven't really checked what population or which sports really creates this.
Because you're concerned about the biceps, breaking the medial wall and then rubbing against the subscap.
Yes,
that
exactly.
would mean that for you need to have an abduction external rotation, kind of repeated kind of micro trauma
or it could be internal rotation. It could be internal rotation and adduction. So it could be any sports doing that. Maybe like golf could be one of the reasons, or any other sports related. But as you know, the number of this patient is not that large, so I'm not sure if I can get a pool on the sports activity that causes this.
Okay.
It's not like you see it like every day.
Do you think it's got anything to do with the coracohumeral distance as well? Have you worked on that?
That's anything's possible. I think that's one of the reasons possible. I think if you have a narrow coracohumeral distance, I think that's one of the reasons that you can get impinge on that subscap and biceps. As you know, the coracoid or conjoined tendon is one of the reasons they impinge on with the left tuberosity. So I think it could be possible.
Okay.
Okay. Do we have anybody has question before we can end the session?
Vishwadeep, answering to your question, like in our scenario, what I have seen in 2-3 radiologists who are doing ultrasonography for few times, like regular they are doing 100, 200 sonographies a day. Those patients, in 2 patients I have come across this concealed lesions, like this cheese cutting of the biceps into the subscapularis, and they have a similar picture.
You mean you could dynamically define this phenomena happening?
No. Now retrospectively, when we are seeing this, like this lesion is there, and when we have gone in for a subscap repair, we have seen in such patients.
Jesse, when you operate this concealed lesion, you always do a tenodesis or you keep biceps as it is?
No. Well, I think the biceps is the main problem. It's subluxating. So you need to either cut it and get rid of it outside, or to see it. That's one thing, or you do a tenodesis and cut it. It's up to you. But I think I think that the main reason is biceps subluxation. So I think you need to get rid of the biceps one way or the other.
Okay. So is there any question, or we can end the meeting, Dr. Abhay?
Yeah, I think we can end the meeting. I have to eat.
Yes. What's the time now?
It's 9 p.m. and I didn't have dinner.
You didn't have. So
yes, that's okay. I'm on a diet with this corona issues, that if you're in your home all the time, you have to be on diet all the time.
So
although you get fat.
Thank you very much, Dr. JC, for wonderful 2 talks. We enjoyed you as it is,
problem.
and you are
Good
always
to see you guys.
most
Be
invited.
healthy.
to India.
help your patients, and
Yeah,
we'll see. So
we'll always follow your advice, Jesse, and thank you for talking to us on very difficult topic of subscapularis tendons, and it has not been very well spoken in many of the meetings. So I appreciate your contribution towards.
no problem.
Thank you. Thank
See ya.
you.
Bye bye, everybody.
Bye. Bye.
Good night.
Take care.